and I've been asked to talk about the treatment of the developmental dislocation of the hip in toddlers. And I think it's important to understand, in order to make decisions on the treatment, on the normal hip growth and development, the pathoanatomy of the hip, the natural history of untreated hips, and the treatment options and indications based on a rationale. The hip during development is always in because it forms by cleft on the cartilage of the hip joint. So all the hips start being inside the socket, and it's through development that a dislocation will happen. The hip is a combination of growth of the femoral head as well as the acetabulum. The femoral head is through the ossification nucleus of the femoral head and the growth plates that will differentiate over time to produce the final morphology of the proximal femoral, which is affected also by the blood supply as well as the relationship with the acetabulum. And the blood supply in the femoral head is actually only through this blood vessel in the corner, and there's a few, maybe 20% through the ligamentum teres. So any decisions with respect to the treatment of DDH have to take in consideration this blood supply on the proximal femur. Now, the normal hip development requires that the femoral head is in within the acetabulum. So the socket is concave to join the femoral head, and the growth of the socket as well as the femoral head is by that intricate relationship. Dr. Poncetti did these studies in the 60s and 70s in which he evaluated just the normal growth of the socket, of the acetabulum, and you have a very complex articular cartilage as well as growth plates that are joined as a Y in the end of the socket, in the deepest part, and this will require the presence of the femoral head. At the same time, at the edge of the acetabulum, there's another growth plate which will generate the final growth of the depth of the acetabulum by another ossification nucleus in this area. So this is extremely important to consider, especially when you are dealing with the labrum. Coleman and et al. Did a very nice experiment in which they demonstrate that the development of the acetabulum depends on the geometry of what is it during development. And in these experiments, what they did is to remove the femoral head, in which case the acetabulum was pretty flat, as we can see also in cases of developmental dislocation of the hip. And then they put a little square in a little piece of metal in the socket, and at the end of the growth, the socket was a square. So the intimate relationship between the femoral head and the socket is very important for the development. And one of the problems with dislocation of the hip is that that relationship is affected for unknown cause. But as a result, there's a hypertrophy of the transverse ligament, as well as hypertrophy of the capsule that also can here on the ilion. And then there's a contracture of soft tissues, especially and one of the most important obstacles for reduction, the psoas. In the bony side, usually there's an anterior acetabular deficiency. However, sometimes it's posterior or global, depending on how long the deformity has been there. And there's flattening of the femoral head because it's not in the socket and it's pushing against the ilion. And there's an increased femoral anteversion. So when you address, you have to address these issues in order to make your decisions about what is the best treatment. However, the young bones have a tremendous ability for remodeling, and not all of them has to be addressed at the same time. And I think in the area of children between 18, 20 months and 4 or 5 years, this is an area of still controversy about how to proceed. The neolimbus here in this arthrogram is the edge of the acetabulum, and here this area will develop the ossification nucleus to increase the depth of the acetabulum, especially in the last growth of the puberty. Several authors have removed the limbus during dislocation of the hip, and that leads to hip dysplasia, so the neolimbus should be maintained intact. As you can see in the study that Dr. Poncetti did about reduction of the hip and how the hip follows in development, in this case is a 3.5 years old baby that was treated for dislocation by just close reduction. And you can see how this area of the acetabulum develops until the end, and then you end up with a hip that is pretty almost normal. So you have to leave this area intact in order to prevent dysplasia to happen. And the acetabulum, and this is one of the main issues with respect to decisions for treatment, has potential for remodeling for about 3 or 4 years after reduction. Although it depends on the starting age. Like if you start in the first years of life, then it goes very fast and it gets to very normal levels. But if you start after 24 months, then the development of the acetabulum is a little bit more impaired. However, still for 2 or 3 years after reduction, you can still get some remodeling. And some authors say that you can get remodeling until 8 years of age. And the final development also depends on how do you start, but you can see that some of these cases don't remodel and usually happen between 2 or 3 years after reduction. So I think there's potential for remodeling for 2 or 3 years, and after that, if you don't have remodeling, then you can act with respect to the acetabular side. Now, what is the natural history of a DDH? Well, if you don't treat DDH, then this is usually what happens in unilateral cases. You will have a length inequality, usually of several inches. You have a knee deformity at the same time. You have pain in some cases, especially when there's a pseudoacetabulum, and then you can develop scoliosis and gait disturbance. So unilateral cases, I think, should be treated in the majority of the cases. There's controversy about bilateral cases, especially after the age of 6 or 7. Now, what are the principles for treatment? Well, you have to maintain a reduction, and you have to minimize, by doing so, you have to minimize the number of complications, which are several, and we will discuss afterwards. And you have to provide an optimal environment for acetabular development. You can do a reduction and you can maintain the reduction, but if the acetabulum doesn't develop, then the end result will be a hip with dysplasia, and then you will have osteoarthritis. So there are different controversies in the hip at this age in toddlers, and one of them is the preoperative traction. Is it necessary? Well, there's people that use preoperative traction for 3 or 4 months, 3 or 4 weeks, sorry, and they say that it decreases muscular contractures, it allows a close reduction, and also decrease the risk of vascular necrosis. However, when one looks at the results in the literature, there's not a lot of evidence that will demonstrate that traction makes a difference on these parameters. And Tony's and collaborators did a study in which ABN was present in 28 when you do traction and close reduction versus 8% when you do a primary open reduction with a traction. The same with respect to decrease the number of dysplasia, McEwen group saw 66% requiring acetabular procedures after close reduction versus 33 with open reduction. But I want you to keep in mind these numbers of 33 and 8%, because those are going to be repeated, and this is one of the problems with open reduction at this age. Schoenecker and Strecker did a study with traction versus shortening, meaning cutting a piece of the bone out the femur during reduction. The numbers were about similar with respect to the age, although the follow-up was a little bit longer in the traction side. But you see with close reduction after traction, you have a high number of avascular necrosis and dislocations with decreases with shortening. So I think when you have a question about, you know, how tight the hip is, I think shortening should be used. And the same with Klisic, and these are much older patients, and they have a fair amount of patients with very good results. The second point is that you have to do an arthrogram in order to assess how the hip is. And there are many different types of hips, and each one is a little bit different. You know, this is about the same age patient. This one is a subluxation, and this one is a complete dislocation with hourglass constriction. So trying to do the same approach for both hips is probably not wise, since this one, the soft tissue, and most of the other pathologies, secondary pathologies, are probably less has less affected than that in this case. Mike Vitale and Skaggs did a review of the treatment at the age between 18 months and 4th year. And you can see here how they, in this algorithm, they recommend close reduction arthrography and adductor tenotomy for the patients at this age. And then if it is reducible, then you go to and the arthrogram is less than 5 to 7 millimeters, so it's a very good concentric reduction. Then you can proceed with the casting in the human position to reduce the pressures on the femoral head, since abduction of 80 or 90 degrees and internal rotation that used to be done before will lead to high degrees of avascular necrosis. If not, then you go to open reduction, and if it is irreducible, then you go to open reduction. Now the question is, what kind of approach should you use for this procedure? And we will discuss a couple of alternatives. After the reduction, if it is a high dislocation and there's a lot of pressure, then you do shortening. And then they talk about the possibility of being stable or unstable, in which case you have to add a pelvic osteotomy. And always do a CT scan for confirmation, and then follow up by a cast, as we will discuss on physical therapy in a few minutes. So the two approaches for reduction of the hip are the anteromedial approach and also the one-stage procedure. With the anteromedial approach, you approach the hip from the medial side, and there are 2 or 3 different approaches. The one we used at the University of Iowa was developed by Dr. Weinstein and Dr. Ponsetti. The positives is minimally invasive procedure. It's a small incision in the groin. You can lengthen the psoas, you can open the hourglass capsule, and you can release the ligament, and you can do a very safe reduction of femoral head. So it's a minor procedure attacking most of the obstacles to reduction. On the negatives is you can do a capsulorrhaphy with potential for dislocation. There are some cases of late AVN. It's difficult to handle the tissue since it's very small incision, and the spica casting is very demanding because you have to maintain the reduction. So it requires a very experienced surgeon, so this is, I think, one of the main problems for this procedure. The spica casting is with a human position in the safe zone, 50-70 degrees abduction and flexion. And when you do the CT scan, just make sure that it's in place. And you just notice here the molding to prevent redislocation. And I think the 2 or 3 cases that you see dislocation is because the molding has probably not been enough to maintain the hip. But this is a technical point that is extremely important to prevent redislocation, since you don't do a capsulorrhaphy. There has been some question about the human position. It allows to center the hip in the best position, which is in abduction. However, people say that it has a higher risk of type 2 growth disturbances because of the labrum can put pressure on the posterolateral side of the femoral head. And also, the transition between hyperflexion to extension might lead to a stress in the capsule and then residual dysplasia. And we will see some data about these two issues. So in the long-term follow-up that we did a few years ago, we evaluated 96 hips, and the age is between in the first year and then up to more than 12 months. So the number of red dislocation was 2%, which is comparable to any other series. The risk of avascular necrosis type 3, which is the whole femoral head, is about 14%, which is similar to other series. And one thing that is important is the high risk of type 2 avascular necrosis, which it was 24%. Acetabular dysplasia 26. In this series, there was no primary acetabular or femoral shortening done. And just remember this number 26 because it's a number that repeats with pretty much every series. Now, the second approach you can use is the single-stage surgical approach with safely reduce the hip and recreates a normal anatomy. The surgical approach includes an open reduction, usually anterior approach. You can perform capsulography. Do not remove the labrum. If it is a problem, you can do some cutting, radial cutting to allow the labrum to expand a little bit. The femoral shortening is important in those cases, especially in the older kids, and no varus component since the normal configuration of the femur is of 125, 130 degrees. And then you can perform acetabuloplasty, and different techniques are used, Salter, Pemberton, or Dega, and it depends on your experience. The advantage of Salter is that redirect the acetabulum. The problem with Dega and Pemberton is that they might decrease the size of the acetabulum, and that is a problem. After the surgery with one stage, you have to use a spica cast, usually 30 degrees of flexion, for about 6 weeks, followed by another loosely fit cast or a Petri cast for another 4 to 6 weeks. And then after that, usually there's no need for subsequent bracing, although many kids require physical therapy for a few weeks to a couple months. And this is one of those cases in which the whole procedure, reduction, capsulography, and with a relatively good short-term result with a very good range of motion. However, this is a major procedure for the hip and also requires a very experienced surgeon. Redislocations is about the same, 2 to 3% reported. Avascular necrosis is about 10 to 15%, very similar to the anterior medial approach. Stiffness is also reported to be 10 to 20% in most series. And it's interesting to see that acetabular dysplasia still is present in the longer follow-ups to about 25%. So although you do an acetabular procedure and you are able to put the place, relocate the acetabulum and the femoral head, still the growth of the acetabulum is affected. And in some cases, it can go in the longer series of 20 to 30 years to 65% of degenerative arthritis, which is very high. And complications like this is a case, 3-year-old boy with this hip. He was treated with shortening and Salter and relocation. It has a redislocation that required further treatment, and then kind of Dega-like procedure was performed to increase the size of the acetabulum. This will start remodeling after a few months. And then 3 years later, you have a relatively normal, good-looking acetabulum with a femoral head. But this is only 2 or 3 years of follow-up, and we don't know what's going to happen, 10 or 15 years later. And clinically, he's doing okay at this time. So when you look at the results of different series, you can see that the mean age is usually around 4 or 5 years of age. The number of hips. And see that avascular necrosis is still high in some of these series, and the same way that there are some dislocations. And when you look at the number of hips compared with excellent results compared with the number of hips, is about 60–70%. So you have to remember that, you know, short-term follow-up of only 4 or 5 or 7 years is not enough. In our paper on acetabular on developmental of the hip, in this case, it's a 45-month-old baby that was reduced. At 9 years, hip looked pretty good. 2 years later, then you have a type 2, which is very common, about 25%. So you have to wait on these patients for a long time before you can say that, you know, the hip is normal. And it's not a benign process. This is a patient treated at 2.5 years with a relatively good hip at 5 years. At the age of 17, a hip that has a little bit sign of dysplasia, but it looks pretty good. 44, start having arthritis, and by 50, have arthritis, require a joint replacement. So DDH still is an enigma. There's things that we can do to put the hip in place, but I think it still is a problem in the long run. Thank you.